Today I'm going to react to Dr. Gavin Chan's video on why he stopped filling tear troughs. My opinion is exactly opposite of his. I continue to fill tear troughs because I think it's safe, it's predictable, and the results can be outstanding. It just takes the right techniques and understanding of the anatomy around the eyelid to avoid complications. I'm an oculoplastic surgeon and I've been doing this for 35 years, so I feel very comfortable injecting tear troughs and I get consistently good results. And we're going to listen to the video together and react to what he says, and I'll give you my opinion on what I think his ideas are, if they're correct or incorrect, and I hope you'll come along for the ride.
Tear troughs. They're the grooves or hollows just underneath your eyes and are a significant cosmetic concern for many people.
I was born with extremely dark hereditary dark circles.
The thing now is really the under eyes, and it really bothered me because the makeup wasn't hiding it. The fact that I wouldn't feel confident without makeup on in this area.
It's no surprise that they are one of the most popular areas on the face to fill with dermal fillers. The idea of a simple, non-surgical procedure to fix what is often a lifelong concern can be alluring for both patients and practitioners. I started filling tear troughs back in 2005. To be honest, the results over 14 years were varied and inconsistent. When I started, I probably didn't know what I was getting myself into. I used to put in large amounts of filler to show a difference and make patients happy at the end of a treatment.
Dr. Chan has recognized that he probably put in too much filler right from the get-go that caused secondary complications where patients were unhappy with the results. I agree with him. I think that you have to put in very small amounts, conservative amounts, and sometimes it doesn't look like it's completely filled at the time of the procedure, but eventually, because these molecules called hyaluronic acid gels attract water molecules toward them and cause a little bit of swelling, you ultimately get a good result. You have to use very small amounts of filler to accomplish your goal. And also the type of filler that you use is very critical. Not all hyaluronic acid gels are ideal to fill the tear trough. Let's listen to Dr. Gavin.
With tear troughs, one syringe, possibly per side in most cases now. And I find, especially with deeper ones, you need the full syringe.
Only rarely would I use a full syringe on either side. And those patients have extreme degrees of volume loss in those areas. I do warn those patients that they may get some post-treatment swelling as a result of using larger quantities of filler, but that swelling will dissipate. It may take a week to go away, and I warn the patient that they should expect some degree of swelling from the procedure itself, and I'll explain why in a few minutes.
Only to find that my patients will come back later with puffiness and overfilling as the filler hydrated. The nature of hyaluronic acid fillers is that they are hydrophilic. That is, they love water and attract many times their weight in water with time.
Then when he did it, I saw an immediate difference and it was crazy.
You can see instantly how it feels in.
What you see immediately after the injection is not a true result. This makes it hard to judge how much to put in at a time. The combination of the hydrophilic nature of hyaluronic acid fillers, the fine skin around the eyes that showed any filler imperfection, and patients that wanted perfection was, in hindsight, a recipe for disaster.
Dr. Chan points to his lower eyelid skin as an area to inject. This area should never be injected right here, the soft part of the lower lid. The injection has to be below the eyelid itself. It has to be firmly on the bone below the eyelid, or firmly in this groove, or kind of towards between the groove and the nose itself, so then I can blend in the material into the groove itself, never on the eyelid, because if you inject the eyelid, you'll get puffiness there and swelling that's inappropriate.
It never really got to a point where I really was like satisfied with it. I had to go back a few times to get it like sort of evened out, and this side was never looked the way that I wanted it.
It's very interesting that this woman who was dissatisfied with her appearance after the injection and never got the result that she wanted, even after multiple visits, actually had a different problem entirely. She had some volume deficit, but she also had a vascular component to her lower nasal jugal grooves, or what we call a tear trough. If you look at her picture closely, she has like a bluish reddish tone to that area. That implies that there are blood vessels that are very superficial in that area. Filling the groove there will not diminish the appearance of that groove. You have to use other topical agents like oxymetazoline or bromidine to constrict those vessels. That goes back to my premise that the tear trough analysis has to be accurate. It may be pigmentation, it may be volume loss, it may be vascular, but if you don't differentiate all three problems, you will end up with dissatisfied ultimate results because you're not addressing the problem correctly.
The past year, I started noticing these really harsh dimples forming underneath my eyes, and I spent the past 3 months going in again and again and again and again and again.
I persisted over the years, chasing that elusive, just right tear trough result. I tried filling tear troughs with smaller amounts, using less hydrophilic fillers, and modifying my techniques in using the use of cannulas rather than needles. Complications such as swelling or puffiness of the lower eyelid were still quite common despite these changes. I was always reassured by what we have been told about the longevity of hyaluronic acid fillers, which is that they only last for 6 to 18 months.
It's not uncommon for patients to come in after they've had a tear trough filling elsewhere and find that they actually have bumps or hard lumps in the lower eyelid. And what has actually happened is not the material necessarily. It may be that the practitioner has used sharp needles to inject the hyaluronic acid filler into the lower tear trough, and it's actually caused a bit of a hematoma, which is a collection of blood where the needle penetrated a blood vessel in the lower lid. That blood vessel, or that collection of blood that results from that bruise, can sometimes organize and get hard. So I have techniques to avoid that problem. Specifically, first I have to prepare the patient carefully that they're not taking any blood thinners of any kind, and that includes aspirin, Advil, Motrin, vitamin E, or fish oil. That's the very first thing we stop way in advance of even coming to the office, usually 7 days to 14 days prior to the procedure. In addition, when they come in, I use an injection of lidocaine with epinephrine, which is a constrictor. And by injecting it before I inject the filler in this area, it constricts those little capillaries in this very vascular area. And when I actually inject the filler subsequently, I don't get the bruising and bleeding that is associated with using sharp needles. I only use, and I am going to emphasize this, only use cannulas in this region for a very good reason, because cannulas are blunt at the end, and therefore if a blood vessel is encountered, it is very unlikely it's going to penetrate into a blood vessel and cause, number one, bruising, but also secondarily it may cause a embolization of the material, which can travel to the eye, which is a serious complication, obviously. So preparation is key, and also technique is key, and also understanding where to inject, namely on the bone and not in the soft portion of the eyelid is key, as well as along the orbital malar groove over here, or ligament. I typically inject a little bit anterior to that groove and then massage the material underneath to get a smooth contour in that region. You can get reliable, reproducible results if these techniques and steps are taken. Now I'm going to listen further to what Dr. Chan has said.
So any complication should be resolved in that time frame, right? After several years of doing tear trough filler, I started to question this, as we had several cases where swelling or puffiness persisted for many years, well beyond the 6 to 18 months we were told that fillers last. Sometimes the puffiness occurred years after having what appeared to be a good result. Some patients had puffiness from filler for years without even realizing it was the filler, thinking it was just aging kicking in.
This puffiness that persists, that I most commonly see, is due to too superficial an infiltration of the filler. You can tell by seeing the patient who has a bluish cast to their lower eyelid. It's called a Tyndall Effect. And that persistent swelling can last several months to even several years. And patients come to me, and I commonly will use what's called Hyaluronidase, which is an enzyme, and it breaks down the hyaluronic acid gel, which is Restylane or Juvederm, and it can resolve the problem. The reason why these people have this persistent swelling is that they were injected with the wrong filler to begin with. Commonly, these people were injected with fillers like Juvederm, which attracts much more water to its molecule than Restylane does. And as a result, these patients can look very puffy, and this material can last a very long time. Selection of the correct filler is also key to attaining the best results. Let's listen further.
To see if it was filler or maybe just fat pockets under the eye and aging causing puffiness, we started doing MRI scans on those with persistent swelling. Due to the hydrophilic nature of filler, filler signal on MRI is white, similar to the signal for water, and its presence is clearly delineated on MRI. What we found was a real eye-opener. We had many cases where we saw filler lasting from 2 to 12 years on MRI. In this interview, I spoke to Dr. Mobin Master, who performed these MRI scans, about his findings. Good to see you. Thanks for coming in to share some of your invaluable insights with us.
Yes, good to see you again, Gavin. Always a pleasure.
Thank you, thank you. So this is the man, a radiologist and a cosmetic physician. He is a guy I send to when I need to see stuff beneath the skin. So he's like the answer book. He gives us all the answers. And I think there's been some huge insights recently in the past year or two, where we've done some MRI scans of patients, and you've found a lot of interesting things.
Very interesting stuff. As you mentioned on the previous longevity interview that we did together, and that actually kind of changed the face of injectables pretty much. It has really changed the way I inject,
changed my practice too,
the way you practice as well, and many other injectors. So the paper in Plastic and Reconstructive Surgery of America was accepted, and it's currently released, and it's on paperback in January 2021, and it describes 14 patients, and we showed that many patients had filler still there after 2 years.
Yep.
One of them was 12 years, and there was still hyaluronic acid filler in the tear trough or in the orbital area.
And I believe out of that study, out of 10 patients who had fillers more than 2 years ago, all 10 showed?
All the ones that had a question of do they have filler over 2 years, all of them had filler.
100%.
Yeah.
There are certain types of fillers that have a lot of cross-linking, and it is difficult in some of those fillers to dissolve the filler with hyaluronidase. The less cross-linked molecules are easier to dissolve with hyaluronidase. So it depends, again, what kind of filler was used in terms of the longevity of these particular cases. The second thing is that I'm questioning in regard to this study is, yes, there may be some deep injections inside the socket of the eye where there are virtually no lymphatic vessels, in the socket of the eye, and therefore that material may last forever. It may not get absorbed like it is around the skin. So I'm not that surprised that some of these cases lasted that long. I am a little surprised that 100% of the cases did last. Some of the material lasted for 2 years. That's my comment about that.
Just over a year ago, I had a patient which I sent to you, and it was a really difficult patient, and she had fillers done in her tear trough, and she had this persistent swelling which just wouldn't go away, and we dissolved it with a bucket load of dissolving or hyaluronidase, and it just wouldn't go away. And I was so puzzled, and I sent it to you. Maybe you can tell us a bit about what we found.
She was a fascinating case, actually, and you sent her to me, and I thought, well, how are we going to work this out? And you said, well, why don't you do an MR? So we did an MRI, and we found that yes, there was filler in the tear trough area, which is, you know, quite typical, and it shows that bright signal on T2, which demonstrates the filler located in the tear trough area. But it also showed post-septal filler, meaning that it was underneath the globe. So it had somehow got under the globe.
Dr. Chan's case in which they found hyaluronic acid gel filler beneath the orbital septum, I believe it was not due to chance. I think that in injecting, in their desire to fill a tear trough, they ended up venturing into below the soft tissue area of the eyelid beneath the orbital septum, which is a barrier inside the eyelid, and ended up depositing the material below the septum. I don't believe it drifted into the below the septum, because the septum is a barrier, external barrier, and I don't believe that the material that was placed externally drifted below that barrier. So I think this is actually a complication of the injector itself, and I would not say that it's due to the material itself. I don't think it's that common for that to occur. I think if people know the anatomy, where to stay in a safe plane away from the soft tissue of the lower lid and remain on the bone itself while injecting with the cannula, I think it's a very safe area, and it's very unlikely that it's going to drift into the eyelid, which is a very resistant area to remove the material once it goes below the septum. You can inject, obviously, hyaluronidase below the septum, but probably when he was trying to get rid of this material, he was injecting externally, thinking that injecting the hyaluronidase below the septum is dangerous. Therefore, I don't believe this is a good example of a significant problem that is common. Even though they've said so in this video that they think it's more common, I don't believe it is.
Given fillers can last a very long time and also have the potential to be injected post-septally or under the eyeball, I needed to make sure that there was an appropriate basis for treating tear troughs with fillers. I started researching this, and I found the answer was right under my nose. I found in 2012, Mr. Brian Mendelsohn published an article titled "The Tear Trough Ligament, Anatomical Basis for the Tear Trough Deformity." Unfortunately, the cosmetic world didn't heed the warning contained in this paper that is almost now a decade old. In this paper, through dissection of 24 cadaveric faces, he found a true osteocutaneous ligament attaching skin to bone in the tear trough. That is, the skin of the tear trough groove is tethered to the bone underneath by a ligament, which means you can't lift it with filler. It's anchored down. It's like the buttons of a mattress, pulling the mattress down. You can't lift these buttons by stuffing more foam or padding underneath them. You can see this when you are squinting. The orbicularis oculi muscle that surrounds the eye moves except for the tear trough where it is tethered down to. Many attempts to find an anatomical basis for the tear trough have been made in the past, with no prior studies finding a tear trough ligament. Mendelsohn states that the discrepancy was from the dissection approach used in previous attempts. Basically, there's been a lot of hypotheses about why there's this hollow trough there, and multiple surgeons or anatomists or doctors have tried to find a ligament there and been unsuccessful. So maybe you could tell us why, what made your study successful. How did you find it when others had failed?
Well, so often with anatomy, it's the way you dissect.
Mm-hmm.
And all surgeons know that. One day you dissect a few millimetres to the side and you see the structures differently from what you're used to seeing. But fundamentally, surgeons dissect by layers, and they lift off the skin, then they lift the orbicularis, and then they go down to the layer 3, where the ligaments may be, and they couldn't see it. And the reason that they couldn't see it is because the ligament extends between the dermis and the bone.
Mm-hmm.
And as soon as you take the top layer off, the ligament loses all its structure.
Mendelssohn's anatomical approach found the elusive tear trough ligament that hadn't been found previously and helped explain the reason why filler simply can't lift the tear trough groove that is held down by this ligament. In his publication, Mendelssohn's conclusion was that filler can be placed underneath the tear trough ligament to support it, but should not be placed above or directly into the tear trough, as this can aggravate the deformity. Given its tough fibrous nature, I feel that filling directly over or in the tear trough ligament commonly leads to extrusion of the filler to either sides of the ligament, which causes puffiness in the lower eyelid. The technique suggested by Mendelssohn of placing filler underneath the tear trough ligament, essentially in the cheek, has become my go-to method for consistently improving the tear trough groove through support of the ligament.
Dr. Chan recommends injections in the cheek to correct the aesthetic problem of the tear trough. It is true that filling the mid-face area right here, this is called the mid-face area, this area can have some positive effect on the tear trough, but commonly you still have to fill near or around the tear trough in order to obliterate some of the depression in this region. You can't just fill here alone and have that correct a distal problem entirely. So I don't agree with his approach.
I never fill over the tear trough groove or ligament now. To see if a patient will benefit from this supportive filler, I perform a simple press test on the cheek. If there is improvement in the tear trough from the test, then it is likely that filler in the mid-cheek under the tear trough ligament will help. Patient expectations are paramount here, and it's important to explain prior that it may not completely remove the tear trough groove, only soften it, and that further improvement may require surgical correction. Surgery should also be presented as an option for anyone presenting with concerns about their tear trough.
It is true that surgery is another option for correcting tear troughs. Surgery in and of itself has its own set of positives and negatives. Of course, undergoing surgery to correct this area is quite complicated. It can lead to prolonged swelling, and it is not without its own set of risks. Not to mention the fact that it's much more expensive and less accessible to many people who want to have aesthetic improvement in this region. So it's something to discuss, but very often people want a simpler solution to their cosmetic concern. Dr. Gavin Chan's video has been very informative. However, I think there are flaws that I see within his analysis as well as his techniques that may have dissuaded him from continuing to want to inject the tear trough. I am in the camp of doctors who believe injecting the tear trough is very beneficial, very simple, and has predictable results in far and away the majority of patients who undergo this procedure. I think there has to be the correct precautions taken prior to the procedure and the correct methods and techniques employed to do the procedure to arrive at a successful result. I hope you found this reactionary video to be informative. If you like what you've seen and heard in this video, please subscribe to my channel, and I look forward to seeing you in my future videos.